so let's get this going too. Excellent. Okay. It is such an honor to be with you here in Pennsylvania. I feel very fortunate and lucky to have a close relationship with Helen. I follow what you all are up to here in Pennsylvania. I think both from the coalition standpoint, but also just your state partnership standpoint, you set a real example for many other states looking to have cohesive, unified partnerships across the state with everybody focused on oral health. I know obviously some of those conversations aren't always fun, but you all do a really great job of it, and the coalition, I think, is much to thank. So kudos, bravo on that front. Today, before you all dive into some of the specific issues going on here in Pennsylvania, what I'm going to do is try to ask you to kind of zoom out, and let's just do a real quick overview of what's going on the federal and national front, and why is it so important that you keep engaged not only at your local and state levels, but also keep being knowledgeable, getting the information, keep engaging at the federal and national level too. So a couple quick things. I have no financial disclosures to note. In case this comes up, we have a project right now that is supported by the CareQuest Institute looking at transition from pediatric to adult care for patients with intellectual and developmental disabilities. I don't directly plan on talking too much about that, but if you're interested, would love to chat more, so definitely let me know. But aside from these disclosures, I have just a couple disclaimers too. For the most part, I don't think I'll be telling many of you much information that you don't already know. I think we're fortunate, maybe is the word, to be at the end of this year where we can kind of look back at what's happened over 2025. So I might just kind of be packaging it a little bit differently. And I hope you leave today with, again, that desire and momentum and optimism about staying engaged and involved, even though we undoubtedly have had some challenges over this year that we'll talk a little bit more about. So I'm coming from AAPD, the American Academy of Pediatric Dentistry. By design, very intentionally, we are not the American Academy of Pediatric Dentists. We are the American Academy of Pediatric Dentistry. We have open doors for anybody who is focused on improving, advancing the oral health of children and of people with disabilities. We have about 12,000 members nationally, with a handful of those being internationally positioned as well. And we love partnering, and I'll chat more about the different avenues that we could partner. Our Research and Policy Center team, or RPC as we know it, is a small but mighty team. We have expertise in public affairs, public health, public policy, library sciences, evidence-based dentistry. We also have an advisory board of some of the best in dental research, in dental public health and health policy. So very fortunate. We put out resources on occasion. We hope they're helpful to you. I'll provide some QR codes at the end, but hopefully, some of what we have may be of use to you in your work. So from an educational standpoint, of course, these are the learning objectives. We're going to talk a little bit about some oral health status updates, advocacy efforts that have been going on over the past year, identify a few areas that are really prime right now to continue working in, and then talk a little bit about how we can go about this effectively. But how we're actually going to do this and hopefully meet these objectives is this game plan here. So talking a little bit about where have we been, where are we now, what can we do next, and how can we do this? So a few of you I've had the pleasure of being with for a couple days at the Medicaid CHIP Medicare Services Dental Association MSDA meeting in DC. And some of the format of this looks very familiar to how we covered this information. And I swear we did not compare notes. But I guess that's how we're all thinking about this right now, is kind of the reflection, where we are now and where we can go. Okay, so where have we been? Again, I'm not telling you much that you probably don't already know. Just a quick review. Over the past 20, 25 years, we've seen significant strides in more children, particularly lower income children, getting into dental care. Not shown here directly, but because of that, we've also been narrowing the gap between publicly and privately insured children. We've been making good progress for a long time. Of course, yes, we saw the dip over COVID. In a lot of respects, that has rebounded. Yes, there are new normals and new challenges from that, absolutely. But in general, if we really zoom out and look, 25 years back, we've made some significant strides. So good news there. We can't forget to celebrate these things. In October of 2022, for the first time ever, every state across the US had some level of dental benefit for those who are pregnant or postpartum. So October 22, at that time, it was a minimum of 60 days. So what you're looking at here is not current, and I apologize, but we've seen so many states extend and expand beyond that since that time. And it was incredibly popular in historically red states, really focused on the pregnancy and postpartum benefits. And a lot of that, I think, has to do with some really great messaging and education that the oral health community was doing with others in the medical community, of just linking pregnancy and oral health and adverse birth outcomes and understanding the whole health system and the progress that we could be making with these benefits. So another huge win, something to celebrate. And I think while we may not right now in the next couple years see as much directly on this because of some of the other challenges, I do think it's an area that we're going to hop right back to at some point in the near future. On the adult front more generally, the adult Medicaid dental population, we were seeing over particularly 2022 and 2023, state after state after state after state make changes and extensions and expansions of their adult dental benefits. Yes, we will talk a little bit more about what's happening on that front too, and where some of these may be being walked back a little bit. But again, I think it's important to stop and celebrate where we were. Okay, another major change that has not been realized yet, but has the potential for the future, is at the end of 2023, CMS, the Centers for Medicare and Medicaid Services, came out and said, if you're interested, states, you can now start planning to incorporate adult dental as an essential health benefit in your plans. We know that a couple states were actively pursuing this, getting all of the paperwork together, their waiver information together to do this. It has not been realized, as mentioned, but again, I think this is an area that will likely be going back to at some point. Okay, so a number of good things that there was tons of progress, and we need to celebrate those. But now let's take a look at where we are now and what's happened kind of in the more immediate future. Okay, so buckle up. We're going to talk about a few things here. We're going to talk a little bit about the oral health federal infrastructure, what's going on in fluoride, what is happening, will happen with HR 1 or Public Law 119-21. Get into more on that in a second. We'll talk about the shutdown, which for those of you who can pay attention to your phones might be, we'll be having updates on this in real time perhaps today. And then briefly, because of course I come from a pediatrics lens, we'll touch just on what's going on the immunizations front too. All of what I'm about to share, I want to flag that we've put out information in greater detail than I can get to today on all of these levels with people on our team and other teams who are much smarter and brighter than I am. So if this next few minutes is of interest, encourage you to check out this webinar. It's free on our website. It's if you scan that QR code, it's there. It'll be in the slides that these links will be in the slides that you get. But we had a couple of my colleagues, Julie Allen with Powers Law, Lauren Mann, who's on our team in the Research and Policy Center, who came from Dr. Chalmers' office at CMS, and then a good friend and colleague, Dr. Aaron Booman of Missouri, who chairs our Council on Government Affairs. The three of them provided some really great detailed updates on what I'm about to cover on the federal front. Encourage you to check it out if this next part piques your interest. Okay, so let's take a step back and think about this year and what's happened over this year. So we, in January 27th, about a week, if not exactly a week, after the new administration came into office, the Office of Management and Budget issued the federal freeze. Does this not seem like 7 years ago? Like it is. I'm like, how is this year? But yes, January 27th, that announcement came up that that there would be funding restrictions, some delays with issuing funds. It was relatively vague. We didn't know exactly which agencies were going to be impacted, but we started distributing information of we know something's happening. We're going to keep watching it. We know many of you, particularly those who are involved in your state Medicaid agencies, who are Medicaid providers, are probably a bit anxious about what you're seeing. And a quick reminder, too, again, this headline, could have easily been missed, even though at the time, I'm guessing most people were aware, particularly those who work in the Medicaid space, is some states' Medicaid portals were not receiving the funding disbursements that they needed. And that happened to be, it was claimed to be a technical glitch. It's a little funny that these things were happening in the same set of about 36 hours. So anyways, that's that, held up in courts. Next, just less than 2 weeks later, was when there was guidance issued about the National Institutes of Health lowering their indirect costs work. So I know that there's a lot of technicality here and a lot of rules. However, it sent the research community into a panic, and that I think includes a lot of dental schools as well, as everybody just struggled to imagine how they were basically going to make ends meet with the existing grant funding that they had. Again, that too was held up and continues to be held up in courts. Now, does some of this policy absolutely need to be revisited? Yes. Was this the right way to do it? I would argue probably not. It seems like the court system is saying that too. But that too was this year. That was early February. Then, end of March, early April, was when we started to see the reduction in force hit the oral health community. The RIFs hit the oral health community. And initially, I think the two agencies where we saw this right away, and it felt a little bit more drastic than maybe we've seen others, was in the CDC, Centers for Disease Control and Prevention, and HRSA, the Health Resources and Services Administration, which I'm guessing most everybody in this room is familiar, but one of the major areas in which they operate is in the health center space. So let's just go over a little bit of the status of a lot of the agencies that touch oral health and where we are now. Okay, so we'll start with CMS, Medicaid and Medicare. So CMS had a small oral health team led by the chief dental officer. For the first time ever, the chief dental officer CDO role sat within the office of the administrator. There had been a chief dental officer before, but it was not positioned that high up in the agency, which obviously is really great for just productivity, cross-collaboration with the other centers within CMS that you would need to get things done, and that was absolutely realized. That team pretty early in the RIFs stage was kind of dispersed within the agency, so that, speaking very frankly, Dr. Chalmers didn't have her key people working with her anymore. One of her key people is now working with me, and I'm so grateful, but obviously wish that that wasn't what she had to experience. So Dr. Chalmers, for anybody who's not familiar, resigned from CMS last week. That was on her terms. I know a lot of folks get that question, but that was on her terms, and now it's very public too. She's going to work at Overjet, and the other folks who are doing a lot of the health services research under her at CMS are still there, but they're not working on oral health. So there really is not an oral health presence at CMS anymore, which is obviously very unfortunate. She had made great strides. I know I've touched on a few things that, again, are kind of coming more from my pediatric lens, but she did a lot on the adult front, arguably more on the adult front too. Okay, CDC, the Division of Oral Health, was swiped completely. So CDC Division of Oral Health is no longer there. There's a lot of question marks about what happens from here with some of their activity related to fluoride and reporting on fluoride status across the states, what happens with state oral health grants, what happens with some of the safety and infection control activities that CDC did. A lot of those are going to be picked up by the Association for Dental Safety. They've really focused on this, but we are seeing there will be some massive gaps, and we're not sure what happens there. The Food and Drug Administration, FDA, we'll talk a little bit more about them on the fluoride front in a couple minutes, but for the most part, they do have some dentists in the agency, and they have some folks who have worked their entire careers in the oral health space. However, they're a little bit more scattered, which in some respects may have been beneficial. There wasn't as we knew, aspects of oral health might become a target for this administration. There wasn't an oral health branch at the FDA to just take that out completely. So them being naturally dispersed throughout the FDA could have been beneficial. It could be beneficial in some respects. We'll talk more about that in a little bit. HRSA, for the chief dental officer, was one of the folks affected by the reduction in force early on. They still have a couple folks with an oral health background. Again, they're a little bit more scattered, and we lost other people to some key people, particularly those involved in some of the grant making that HRSA does. We lost some really phenomenal project officers on that front. So we'll see what happens from here. Let's chat a little bit more about this too. IHS, the Indian Health Service, for the most part, fully intact. A lot of the dental folks who were there are there, and they're picking work back up. That was kind of paused for a little bit. That happens in a lot of administrations, but definitely this one too. They fared well in that process, and that might very well be due to some strategic priorities of the administration too. NIH or NIDCR, there have been proposals about folding that into another new institute on neuroscience and brain research. I'll chat about an update on this in 1 second. And then USDA, which oversees SNAP and WIC. I'm sorry that I don't have specific information on their staffing, but we will chat a little bit more about what's happening on the program front on that. So, mentioned the NIH issue. Throughout all of this, there were a lot of national organizations stepping up and voicing, gosh, we got to be careful about these cuts. We're going to need these programs and these services and these folks working in these areas. So let me just flag one area here. Right now, it seems as if, at least for the moment, we can be optimistic about NIDCR at the NIH staying in its current state. Now, that is definitely not a promise. These things can change very quickly. But I think there was really good advocacy from a lot in dental education, from a lot of folks in other parts of organized dentistry, oral health, the research communities in general, saying we cannot get rid of NIDCR as it currently exists. And I think one promising note on that front is just in the last week, did they actually post the position for their new director. So I do think this is one area where the oral health community at large, research community, dental education really came together and did shape this, because I think had we not spoken up, it would have gone more easily. Some of these other items I'll get to in a little bit. Okay, but let's talk about fluoride, shall we? Super fun. So again, want to zoom out and provide a little bit of a timeline here on what's happened on the fluoride front. And I'm going to go back further than this year, just to remind folks, again, you know a lot of this. In August of 2024, the National Toxicology Program released that report known as the NTP report that you've probably heard about or seen in the news. And that there's a lot that's behind that that's not commonly known, that was not really picked up. And one of the major questions of that report was, well, how did it get released? Because folks have heard that NASEM, the National Academies of Science, Engineering, and Medicine, raised some red flags about not releasing this report because it was not based on sound evidence. Well, what folks don't know as much and wasn't seen as much is that that report was released from a Freedom of Information Act request, a FOIA request. So NASEM had said, don't release this report. They actually said that twice. They reviewed multiple drafts of this report after they went back and fixed it. And NASEM was still saying, this is not, you cannot draw the conclusions that are in this report from the science you're presenting here. But eventually it did get released because of the Freedom of Information Act request. The next month, October of 2024, was when the Cochrane updated report came out. And this was really, I would say, misrepresented in the media as well. One of the conclusions was that the benefits of water fluoridation are no longer what they once were in 1970. And that is exactly what we would expect, because there was not fluoride in toothpaste at that time. But it was really kind of flipped in the media of, look, this serves no purpose anymore. So that was October 2024. In November 2024, with the election, I think that's when we started to see, okay, RFK Jr. is really getting a podium right now. We know he has some concerns on fluoride and water fluoridation. And we've got to understand that this very well could become a priority for this administration. In January of 2025, there was a JAMA Pediatrics article that came out that everybody thought and was presented in the media of, oh, this is new science and new evidence, and it wasn't. It was the exact same information as the NTP report, presented in a different format. But everybody said, well, look, there's now this too. Not the case at all. Same information, same science. March of 2025, earlier this year, was when House Bill 81 passed in Utah that would no longer allow community water systems to be fluoridated. And just a few weeks later, actually while the National Oral Health Conference is going on, and I know some of you were there, we heard the announcement that Secretary Kennedy would be traveling to Utah in short order to celebrate the signage and the passage of that bill. And that's when we mobilized and tried to get partners in the oral health space, in the general health space, convened and coalesced around supporting water fluoridation. And my gosh, did they all come out. Shout out to Pennsylvania too. I think there were 9 or 10 organizations from within your state that signed on to this support letter for water fluoridation that went to every member of Congress, both House and Senate, and went to Secretary Kennedy and some key offices within HHS. So 250 organizations, the American Academy of Pediatrics, American Dental Association, Families USA, NAPNAP, the Nurse Practitioners Association, many other orgs. Again, there were like 9 or 10 from Pennsylvania, so many, many thanks for the support there. Okay, so that's leading up to May. And then we get into the supplement space. So early May or mid-May, I guess, is when the FDA came out with an announcement that they would be monitoring and perhaps regulating fluoride supplements in the time to come. And they noted October 2025 as a deadline for some key decisions on how they would go about doing this, what the specifics were. So we started notifying some folks and key partners. Soon after this announcement, they also announced that they would be convening a summit with an organizational partner of the FDA, the Reagan-Udall Foundation, in July. And they set an agenda with some pro-community water fluoridation representatives, some anti-water fluoridation or anti-fluoride representatives, and they hosted that meeting in July. Our representative from AAPD was Dr. Tim Wright, who's the editor of JADA, and many folks had opportunity to share testimony, respond to key questions they had. And of course, as you've heard in the news and might know very well, some of those questions related to science that was drawing an association between fluoride exposures and neurocognitive function, gut microbiome issues, et cetera. A lot of this, again, a lot of the underlying science related to this, the NTP report, was all drawn from low quality evidence and or areas where fluoride levels were naturally much higher than what we see in the United States. So that meeting took place in July. Lots of great representation from the oral health community. And then last week, 2 weeks ago, on Halloween, just in the nick of time for their October 2025 deadline, they did indeed release some information about their intentions on this. And you can find it easily on FDA, especially if you go to FDA press releases. They issued warnings to, I think, 4 manufacturers who offer single ingredient fluoride supplements, so just fluoride alone. And they produced a report from that July meeting. Now, we came out, as you see here, with a statement about this. And we, in that statement, let me get back to one of the other specifics. In the FDA announcement, they warn against the use of fluoride supplements for children under 3 altogether. And then for children 3 and above who have low or medium caries risk. So this is not much different than what already existed at all. So the advocacy and the work that was done in this time from May to October worked. Not entirely. There is absolutely still a need for high-risk children who are very young, who don't live in areas with water fluoridation, to have fluoride supplementation. Absolutely. So I do not want to send the message that we're not concerned about that, because we absolutely are. But the message here is, for anybody who was following the July meeting, it was very clear what FDA's intentions were to wipe this option for fluoride completely from the market, and they did not do that. So I think we were really effective, and in their guidance, they note that they see the benefit for high-risk children in some instances to have fluoride supplementation. The other key note here, especially for any clinicians in the room, is that the FDA does not have regulatory authority over multivitamins. And there are multivitamins on the market with fluoride. They cannot and will not come after those. So that is another message for clinicians that we've been spreading. And we've worked very closely with the American Academy of Pediatrics on this. And we've started sharing that information in September of if you're not in a fluoridated area, if you're a prescriber, if you're prescribing single ingredient supplements, you might want to think about making this change to a multivitamin. This is absolutely not an endorsement of any particular product, but a lot of folks who aren't familiar say, well, what are those? So, some of them are like Polyvi-Flor, Q-Flora, Floriva, some of those names that might be new, but those are multivitamins that have fluoride in them, and that's one of the messages for our clinicians, and a lot of times our pediatrician colleagues, most certainly, that we've been sharing. Okay, so let's see if this works. Okay. Let me actually chat through this, then we'll see if this video works. But another piece I just want to backtrack to on the fluoride front is we have been successful in having dentists in Congress and physicians in Congress speak up and raise the red flag on this, that there is support for water fluoridation, and they've challenged HHS and Secretary Kennedy, and they're not scared to do so. I want to flag, too, that this was not, so here what you see and what we might hear in just a second is Congressman Mike Simpson of Idaho, and also want to flag, it's not just his team that kind of prepared him for this. The American Dental Association was right there with them helping. So you don't always hear about these things that are going on behind the scenes with some of our partners in organized dentistry, particularly the ADA. And a lot of times that's strategic. It's a means to an end. They can't speak up about some of the work they're doing kind of behind the scenes. But they really worked with him to figure out lines of questioning and what to prioritize. On the state and local front, I apologize, this is very much out of date, but we have seen a lot of successes that you don't hear much about in the news. So Louisiana voted down a potential ban, so they are allowed to continue with water fluoridation as local communities or water boards decide. Nebraska, a fluoride ban law died in committee. Arkansas, they preserved a water fluoride support bill. I'm forgetting the exact language, but they preserved that this year. And kind of funny, even after the fact, when we saw the ban go into effect in Florida, was many Florida communities, or a handful of Florida communities, were voting to preserve. And then kind of happening at the same time was the statewide ban there. And this is an outdated list. There are many more. Even last week was getting alerts of some local successes that have been happening. Okay, let me just see if this quick little clip of Congressman Simpson.
I am concerned about the fluoride issue. I've seen the benefits, having been a practicing dentist for 22 years. If you are successful in banning fluoride, I noticed you congratulated Utah and Florida, I think, for banning it. That's up to them. They can do what they want. But we better put a lot more money into dental education, because we're going to need a whole lot more dentists.
I think that, Marty McCary's concern with ingestible fluoride is that the emerging...
Okay, so, and the ingestible fluoride then, led to the FDA supplements and all that. Okay, so these links will be in your slides, but just wanted to share some fluoride resources. CareQuest has done a really great job of keeping track of what's going on at more state level. There are a lot of groups focusing on the local level who kind of share information and respond on the local level. Again, this will all be available to you. Okay, HR1, tons going on here. We're going to put a pin in some of this. I'll cover it briefly, but want to, on this slide, just quickly mention, in terms of the Affordable Care Act, obviously this situation and what's going on with tax credits is unfolding perhaps as we speak right now. But there are some concerning developments in terms of just the open enrollment period being shortened. And obviously, as mentioned before, the adult essential health benefit probably will just sit there for a while, and we recognize that. On the rural health transformation, for anybody who's not familiar, $50 billion will be invested. This was one of the only kind of additions or positive gains, I would say, from HR1 in the Medicaid space. Half of that money is more or less guaranteed to every state, split by every state. Half of that money is being awarded on a competitive basis. These dollars will be distributed by the end of December. Every single state put in an application for these grants, every single state. So that award, the $25 billion of that is awarded on a competitive basis, TBD on how that plays out and how it gets distributed. We also do know that at least 2 states had a very solid oral health component built into their applications for these rural health funds. Student loans, I won't get into much here, but some scary developments potentially for dental education, very scary in the years to come, knowing how expensive dental education is. Encourage you to check out that webinar I mentioned before where we go into a lot more detail on the student loan limits. Okay, so let's jump into some of the other Medicaid provisions as part of HR1. Very early in the year, many organizations were coming out to say, gosh, we got to be careful about cuts that we make to Medicaid. And this was a moment when so many different communities who often aren't at the same table or really partnering came together. So we saw, patient advocacy groups, provider groups, payer groups all come together and were united on a lot of these please save Medicaid efforts. We also, from a pediatric standpoint, did raise the red flag. We knew everybody knew at the time, based on the provisions that were being considered and were being covered in the media, that there probably won't be as much of a pediatric impact because of the protections that exist within Medicaid that would really rock us all if those were messed with. But we wanted to say, if you care about kids, you better care about parents. And we have really good reason to focus on that. There's been excellent research done in the last 5-ish years from some really smart people who have looked at what happens to kids' dental care and kids' outcomes when you mess with parents' coverage and access. And when you undermine parents' coverage and access, you end up with kids that have more decay. The children of parents who do not have adult dental benefits or access end up with more decay, more likelihood of foregoing necessary care, and less access themselves, not getting into dental care themselves. So we know that there is clearly a link here, and we need to be thinking about parents, and we know that. But of course, at least from our membership and a lot of pediatrics focus, we were getting questions of, oh my gosh, what's going to happen? And we're just trying to educate on, look, we think from a direct standpoint, the pediatric benefits are not going to be directly impacted, less, universal cuts that might happen in programs, but we need to be focused on adult coverage too. So a couple quick notes on some of the specifics. We do see the mandatory work requirements were embedded into that. We've heard that in some states that are figuring out how they're going to manage these processes, one state in particular has listed a price of this as $7,000 per enrollee impacted, and it's clearly going to be very expensive to roll this out. And what we're hearing at the state level is that there's a lot of confusion on how this will work. Eligibility redeterminations, what we're hearing is that a lot of states were struggling enough as it is with the frequency of maybe doing this every year, and now thinking about doing it every 6 months is going to be way more expensive for state Medicaid agencies. From a cost sharing standpoint, we're concerned if we see adults have to fund more of their care. We, from pediatric standpoint, worried that these kids too will suffer in that process again indirectly. Okay. As you all know, there is a staggered implementation with all of this, so the effects of it will seem dampened. Obviously, SNAP in recent weeks has been very much in the news. Just want to flag that work requirements will go into effect for SNAP as well, and that includes they removed some exemptions. So previously, if you were a parent of a child with disabilities or with special health care needs, you were exempt from those work requirements. Initially, the House version of the bill said that anybody with a child 7 years and up would still have to meet those requirements. The Senate version said 14 years and up. So when you get to the teenage-ish years, those parents will still be subject to the work requirements. ABLE, aside from the Rural Health Transformation Program that was mentioned, ABLE, the Achieving a Better Life Experience, I think, funds, which is building personalized funds, bank accounts, and the rules that exist for that for people with disabilities, there was added flexibility. So I think this is another one of those stars of HR 1 that made some improvements via these interconnected programs that exist. We've been trying to educate our members on opportunities to just engage and be informed at the local level, particularly as it relates to Head Start, SNAP, and WIC. I'm sure many of you here in the room might be connected or directly involved with these programs, so thank you. We know, at least from our membership, that many folks are wondering how they can help locally, what they should be paying attention to. In terms of immunization schedules, you might recall that in June was when the Secretary Kennedy made some changes in the advisory committee overseeing insurance and immunization schedules and immunization practices. There are ongoing issues that are not fully resolved that we know are being talked about. There was, as already in effect, is less priority on COVID vaccination. There's been talk about HPV vaccination that is mostly rested in the FDA committee, not necessarily ACIP yet. There is talk about separating out the MMR vaccine, which would mean parents need to present their child for more instances of care, not having those all together. Because of all of this, the American Academy of Pediatric Dentistry is now endorsing the American Academy of Pediatrics immunization schedule. We are no longer endorsing the CDC vaccine schedule. A couple quick things on what's been going on Congress. Again, they're small snippets of the larger picture, but pretty, in some respects, positive. So Title VII, which that name might not be familiar to many, but it's Title VII of the Public Health Service Act, and that's what funds the postdoctoral and predoctoral training grants that come out of HRSA, as well as the Dental Faculty Loan Repayment Program. And the administration initially removed that line item from their budget. It has been preserved in the House and Senate version. So we are very optimistic that once we do have a budget and we're a funded government, that Title VII will continue to exist. There are still concerns about who's going to run these programs. Already, I think some of you involved in dental education in the room would typically be waiting for that predoctoral education notice of funding opportunity to be released like now. and we don't know if anybody's working on it. And we don't know who is there to work on it. So a lot of question marks based on lack of staff. However, these programs, theoretically, it looks promising to get them funded. Funding is only guaranteed for the existing ones until September of 2026. So a lot to figure out before then. The Ensuring Lasting Smiles Act, which is a bill that would help folks with craniofacial differences in the private market be able to get medically necessary services throughout their lifespan. We've seen a lot of momentum on this over the shutdown, which is really interesting. I think offices in Congress and staffers have time to read and reach out to their colleagues and say, sure, sign me up as a co-sponsor when you can. So lots of momentum here, even over the shutdown. Okay. I'm going to fly through this and then happy to take questions. So what's next? Obviously, at some point, would love to get back to strengthening Medicaid programs, not just preserving them. We've had lots of really good conversation with partners in Head Start, WIC, SNAP, home visiting over the last couple years, the disability space. We want to get back to that, but right now, yes, we've been in preservation mode. Also, one piece, re-engage with rulemaking. We typically are very communicative with different agencies in the federal government, CMS, HRSA, many, and we haven't had as many opportunities to do that in this administration, and they have been public about that they're not planning to issue as many public comment periods. We hope to get back to that because it's been very effective in the past. Want to just quickly note one state example of that where we've chimed in. Alaska implemented a policy, not to throw Alaska under the bus, but here we are. They implemented a policy that would require prior authorization for stainless steel crowns if you were delivering more than 3 stainless steel crowns. So for kids who were needed to get care in a rural area and had a provider flown in, they were all of a sudden getting denied if they did more than 4 stainless steel crowns. We stepped in and said, we don't think you know what you're doing here. They continue to work through it, but please keep us in mind if you have any issues, if we can help. I do want to, so here I'm going to quickly sound like a little bit of a Debbie Downer, and I don't mean to at all. I promise it comes from a good place. I think in the oral health community, we often have this challenge with lack of specificity. We talk about these big concepts like workforce and payment policy, and of course all those things need to be fixed, but of course all those things need to be fixed in every industry. So I think where we need to focus is getting down to the nitty-gritty of what exactly is it that we want to change. And so when we're working with partners, that's kind of what we challenge as that first step of show us the exact policy in what words we need to change, and then let's chart a course forward on that. One recent example of this is on our work related to ensuring operating room access. So I won't get into that. I've talked to a lot of folks about this in the past, but it was a really good example of what can happen when you identify what needs to happen at the federal level, what needs to happen at the state level, and what needs to happen at the local level. And when you're very prescriptive about those things, oftentimes you can see progress more quickly, get things done, and we've been fortunate to make some good progress there. So all of that will be there if you're interested. I want to flag a couple other tools that might be helpful to your work. The Georgetown Center for Children and Families provides some excellent data on children and families, particularly as it relates to income, social determinants, Medicaid, et cetera. Always encourage folks to turn to the Dental Quality Alliance data dashboards, really good information on a lot of different measures. The Health Policy Institute, HPI, has a lot of great information on Medicaid, on network adequacy, on provider participation, reimbursement rates. Oh, so many partners we can all work with. And I promise this is true. When we're working with state partners at the state level, one of the first folks we always tell them, have you reached out to your oral health coalition? Because we know oral health coalitions are doing such great work. Okay, so real quick, I think there are two sides to every coin here. I've heard a lot of folks say oral health is under attack right now in the federal government, and that might be true. At the same time, maybe we can be grateful that we're in the spotlight and have a podium right now. People are paying attention to oral health right now like they never have before. So let's use that. It's not all doom and gloom. We have been unified. The broader healthcare community, policymakers are joining with the oral health community. That's shown here in this room today too. So we're moving less backwards than we could. And I think everybody's recognizing that a lot of folks, we need a lot of different perspectives and stakeholders in the room, and we have to collaborate, and I think we're doing a better job of that than maybe we have in the past. So please, while some of this is a little bit scary and a lot of the impacts are yet to be seen, please don't step away from engaging at all levels, local, state, federal. We need advocacy on the oral health front more than ever. I'll leave, of course, these QR codes, some links, not exhaustive at all, but other tools we frequently have are there as well. And that is that. So thank you so much.